Simon, thank you. Thank you to the committee for inviting me. Thank you for listening today. So in true UCL rebellious format, I've changed the title again. So is there a role for salvage therapy, sorry for the typo. So the NICE recommendation for men who fail radiation is to not routinely offer hormonal therapy to men with prostate cancer who have biochemical relapse unless they have symptomatic disease progression, proven metastases, or a PSA doubling time of less than 3 months. That was in 2008, and that hasn't changed in the latest draft guidelines. So we know that 1/3 of men may experience biochemical failure at 5 to 8 years following external beam radiotherapy. That might drop with dose escalation, increasing the number of grays, but we think it's about 1/4 to 1/3. And of those men who do fail, about half have micrometastases or overt metastases within 5 years of biochemical failure if they do not receive salvage therapy. So local salvage therapy could be curative in men with isolated recurrence. And this is clearly something that is a lost tribe in terms of management of patients. We haven't really been focusing our attention on this group whatsoever. And Steve Jones certainly agrees and thinks this is an emerging and largely mismanaged epidemic. So the standard of care, as we all know, is watchful waiting, essentially palliative care with delayed androgen deprivation therapy. And that has advantages and disadvantages. I don't think many men like to be on hormones, and it's certainly very costly, and it then leads on to costly systemic therapies when it does eventually fail. So I do agree with Professor Heng-Lung that delaying the onset of hormones is certainly a clinically valid outcome in this group. We've heard about current local salvage treatments in terms of whole-gland. I don't think any of us would agree that this is an ideal treatment, although in some men it is a suitable treatment and an appropriate treatment. The advantage is that it does treat the whole gland in what is a very high-risk disease when it does recur, but it does have significant morbidity. And I think if you look at all the accruals in the series that have published, even James Eastham does probably 15 to 20 a year in Memorial Sloan Kettering. So it's very small numbers. Patients, physicians, oncologists, surgeons don't necessarily favor this treatment. When you look at other whole gland therapies, cryotherapy was summarized very well in the previous talk. And overall, I think if you look at the sort of average outcomes, it's about 50% biochemical-free survival rate in the short to medium term. And I'm sure with longer follow-up, that will decrease. Incontinence, again, can vary and can be as high as 50%. Rectourethral fistula, when it happens, is a devastating complication for those men where it does happen. So trying to avoid that and minimize that as much as possible is absolutely crucial. So focal salvage therapy, why focal salvage? Well, localized recurrence usually occurs at the site of the primary index lesion. Even if multifocal, there's usually one dominant lesion, which has the highest grade and the volume. And MR imaging seems to have a very high positive predictive value, multiparametric MRI. And the functional impact from early case series seems to be lower after focal salvage therapy compared to whole gland, although not in a randomized fashion. So why not focal salvage? There's no definitive proof that, certainly in the radiorecurrent setting, the index lesion drives the natural history. And ruling out metastatic disease, I think, is the major problem that we have in this group. So the current research questions we have is, can we accurately rule out metastatic prostate cancer? Can we accurately rule in localized disease with targeted biopsies? I think we can with template, but can we do it with less morbidity from other types of biopsies? And can focal salvage therapy targeted to the area of recurrent cancer within the prostate reduce side effects and complications with acceptable, possibly iso-effective cancer control? So ruling out metastatic disease, these are about 160 men, 157 men who were referred for salvage therapy over the last few years to UCH, over the last 3 years. And of those, about a third had metastases on either bone scan or choline PET, and most of them were detected on the choline PET. And you need both, because even the bone scan picked up 4 men who had metastases that were not seen on the choline PET. This is just one example of the choline PET picking up a lesion in the bone that wasn't picked up by the bone scan. So whole body MRI seems to hold promise, and there's good data from other centers showing that it might be cost effective in terms of reducing the number of scans, choline PET plus bone scan plus pelvic MRI. And if you can do it all in one, then that might be as effective with less cost. This is just an image of a whole body MRI showing metastases in the spine. Ruling in localized disease, multiparametric MRI seems to be very good in this setting. This is a T2-weighted MRI, which doesn't show much. This is a diffusion-weighted MRI, and again, a dark spot. Sorry for the resolution of this. And when you look at a high B-value diffusion, this lights up like a light bulb, although the resolution of the rest of the gland is very poor in these types of scan. When you give them gadolinium, these guys really light up where they recur, and it's because of the background fibrosis that you get from radiotherapy. When we looked at this series was looked at by Abby, one of our research fellows, and presented at EAU this year. And we compared MRI targeted biopsy. These men all had template mapping biopsy. And of the 24 men who had clinically significant disease, as defined by Gleason 7 or more than 3 millimeters of disease, 20 were picked up just by the MR targeted biopsy. And actually, the template missed or misclassified 2 men who were clinically significant on the MRI targeted biopsy. So MRI targeted biopsy seems to have very high performance characteristics in a small population. Focal salvage therapies holds promise. We've done about 100 now, but this is our first published series of focal salvage HIFU. And this is the same man that I showed earlier. He had a hemiablation of that side. And we think quite a few of these men can be suitable for focal salvage therapy. So when you apply template mapping biopsy, about 2/3 to 3/4 are suitable for a focal salvage approach. So I'll just quickly flick through that. Sorry, these slides are slightly out of order. So this is the same man. He had focal salvage therapy, stopped his hormones, was pad-free, leak-free, but he was impotent, and that most of these guys are, and the PSA remained. The hormones were stopped at the time of treatment. Some of these men come with hormones from the oncologist, which we try to discourage. These are our series. Sorry, this is a busy slide, but just to show you that these are generally higher risk men on their pre-radiotherapy characteristics. We tend not to, at UCL, apply any upper limit. We tend to give men the benefit of the doubt if they have presumed localized recurrence. So that means we do operate on quite high-risk guys. Usually it's the last chance saloon for these guys to avoid hormones, and we do our best to try and treat them if we feel able. And we don't apply any upper cutoff on the Gleason grade, although I suspect we may in future. And these guys do hit side effects. So incontinence, requiring pads, at least 1 pad a day, it's about 12-13%, which fits with the literature. And then any leakage at all, which I think should also be reported by every single series, is again about 35%. So these are pad-free, leak-free rates. And the biochemical control, again, it's about 50% at 2 years. Again, we apply no particular upper threshold on risk of disease at the time of radiotherapy or at the time of failure. So we get a few more failures than we would normally expect in traditional series. Cryotherapy, there's been a recent paper in Focal Cryotherapy comparing it to whole-gland cryotherapy by the USC group. And again, really very nice outcomes. If you look at their accrual over the last 10 years, they did about 2 or 3 a year. So very few were being done, but nonetheless, these are really good outcomes in terms of incontinence, potency, and a lower fistula rate. Our fistula rate is about 1 to 2%. And if you look at the biochemical outcomes, all patients, the PSA does drop where they have no biochemical failure. You can see a really nice PSA response when they do have biochemical failure after cryotherapy, whether it's whole gland or a focal, they have similar types of response, interestingly enough. So there's clearly a research need in this area. NICE recommend it's one of their top 5 priority research areas that we should set up clinical trials in the salvage space. BAUS have prioritized this as a research question as well for high-risk localized prostate cancer. This is, in my mind, high-risk localized prostate cancer if we can do that. So we've set up a NCRN trial. This is funded by multiple partners, the US, NIH, Pelican Cancer Foundation, Prostate Cancer, and the Wolfson. This is called Forecast. And our objectives are to evaluate the accuracy of whole-body MRI to detect and rule out regional lymph node and distant metastatic disease, to assess the accuracy of local multiparametric MRI in detecting areas of radio-recurrent disease using targeted biopsies, and to determine more accurately in a prospective manner with validated questionnaires the urinary incontinence rate and other functional outcomes, but primarily urinary function after focal salvage therapy, whether it's cryo or HIFU. So in conclusion, up to 1/3 of men treated with external beam radiotherapy may experience biochemical failure. There is an urgent need to find new tests that can accurately rule out distant disease and accurately rule in localized disease, and focal salvage therapies may have a role in making local salvage therapies more acceptable by reducing toxicity. Thank you very much.
Thanks, Hash. Thank you very much, Hash. Maybe we have got time for a couple of questions. It looks like focal's the way to go if the patient is suitable for it. Please come up, and would anyone like to ask questions about this interesting developing area? Yes, Nigel. Nigel, come on.
Just one comment. In my experience, with these patients, most of the ones that I see, I've actually got very small prostates, after the radiotherapy. We're talking about, an average between 12 and 20 cc's, really, yeah? So when you do, certainly with regard to cryotherapy, when you freeze, one side of a very small prostate, you're freezing, most of it, really. It's not like, freezing a 50 or a 60 cc gland and just doing, a hemi, ablation, yeah? I don't know how you translate that over to salvage HIFU. Perhaps salvage HIFU is more precise and you can actually, just treat, one half of the gland. But I just think with cryotherapy, you're more likely to be treating the majority of the gland anyway, even if you, try a focal approach, yeah?
So I think that's a good question. So we get a whole variety of gland sizes. I think some of the older radiotherapy regimens, which are now starting to fail 5-10 years after, we get all kinds of gland sizes. There's huge, sometimes very large, and you wonder whether they've had any radiotherapy at all. So I think a proportion will have disease amenable to focal salvage cryo. I think HIFU doesn't have any washout into the other side, so you can be a bit more precise. We've started cryo as a complementary service at UCL. Manit Arya leads that service, and primarily we use it for anterior disease. HIFU is pretty good for posterior disease. With anterior disease, we think it probably struggles to get that energy through and requires an interstitial needle-based treatment. So I think it's complementary. I think the reason why we've included both is because it's not either or. For each patient, I think we will decide what is best for that characteristic and that morphology of disease recurrence in prostate.
Can I just comment also? I would agree with Nigel's comments that most of the post-radiation prostates are small, and I think the larger size would be the exceptions. In terms of focal therapies, in my mind, I think picking up Nigel's point is that if it's truly focal therapy, I think we should be looking at a treating the index tumor with cryoneedle, directly hitting that. I think that would be the definition of focal therapy. The problem with both kind of treatment is there is sanctuary site that you will not treat with either options. With the warming tube for cryotherapy along the urethra, particularly the apical part of the prostate, you will not be able to treat. And I suspect you will also not want to treat too close to the urethra with the HIFU also. I think those are the real issues that we face with both treatment modality. I'm just very anxious about focal therapy in the absence of really good imaging tool to assess tumor locations and tumor volumes and to have imaging modality that actually tell us about the biology of the cancer. I think we are running before we walk.
Okay, that's an interesting. Alan, and then Tim's got the microphone.
Same question I asked Steve Langley yesterday. What are the chances of this treatment ruining my life? Either of the treatments, which might be relevant for a patient.
I want to answer this first. I do radical prostatectomy, and I do not lose any sleep. I do salvage cryotherapy, I do lose sleep. But the patient have had radiotherapy. Their options are not very many. And when I counsel my patients, I tell them they might have to have a ileostomy or something else. So that is the bottom line. That is the dilemma. That is the dilemma. That is the dilemma because we are looking at a group of patients that we want to avoid invasive treatments. The risk of their life being ruined is probably about 2%.
It's about 1 to 2%.
Yeah.
So fistula will ruin your life.
But of course, ruin is a relative term. Somebody may be very happy, outgoing, plays ball all the time, and if he has a bit of incontinence, that can ruin his life, but not major way. So it's all very relative. So 2% is not really answering your questions.
Thank you. Okay, it was Alan and then Professor Damien Green. Sorry,
I've got the microphone. So the thing that really I find interesting about these talks, which I really enjoyed, is if a third of patients are failing radiotherapy, what are the oncologists offering these patients? What's actually happening in clinical practice today? I suspect what's happening is they come back and their PSAs are starting to rise. We know as urologists, if we provide the biopsy service, that they're not sending a lot of them for biopsies. So they're just monitoring the PSA. I suspect that they just go back on hormones. I mean, I think that we need to get the message across that, if a third of patients are failing radiotherapy, and if you can cure 40% or more with salvage therapies, whichever one you use, I know there are significant morbidities, but they're still acceptable. Surely, the message needs to be got across to the oncologists that they're not really serving those patients well.
Fine, and also the commissioners, because as I said, they're often not funded. Alan.
Sorry, with relation to what I said yesterday about framing the information for the patients and taking into account Tim's point about wrecking lives, my worry with treating high-risk prostate cancer per se is getting the sequencing right so that we minimize absolutely to zero the lives wrecked. 2% is still 2%. How do you inform your patient of how much impact it's going to have on their life if they get a fistula? Because it's really, and I don't want to preempt Lawrence's talk too much, but it's really difficult to fix. A lot of the side effects of surgery are easily fixed.
So we have a lot of guys who say no. So we go through, and similar to what Heng Lung said, these are the difficult cases that we worry about on our list because you just can't predict whether they're going to get a fistula. So they have to be really well counselled. I think Manit may be in the audience. He does the salvage clinic, and it takes a long time to counsel these patients and go through their risks. So we spend a lot of time, and quite a few do say no. So and sometimes they say no right at the last moment after they've gone through a choline PET, bone scan, MRI of the prostate, template mapping biopsies, and right at the last moment they still say no after we've fully characterised them. And you just have to be honest and do that counselling well. We don't do it in a formal shared decision making, but this is the sort of area where I think that could really help.
Yes.
Just on the issue about trials, I mean, we've seen it, Tim Douglas from Salvage, sorry. Trials have failed in a number of areas because of problems with equipoise or patients sort of deciding their preferable treatment and it's accessible. You know, if somebody was to come up with a new chemotherapy agent and the patient really like the sound of it, there's no way you have access to that without the trial happening first. And so we've got a problem with surgery that we have to sort of learn how to do these techniques before we can perhaps evaluate them properly. But then I think at the point at which we need to evaluate them, we should perhaps restrict open access to those therapies so that we can actually recruit to those trials. And we've seen Loughborough fail, York trial fail. I think perhaps if we're about to launch a trial, we should actually restrict access to the normal NHS service.
I mean,
Him, would you like to just quickly respond to that before we move on?
Yeah, I mean, I have nothing else to add to that. I think there is the issue of patients' acceptance. But if you look at that and look at the overall acceptance rate, actually, the fundamental issue is that we actually have too few patients referred. If you look at the percentage of patients who will be failing the radiotherapy, we have only seen a fraction, tiny fraction of them. I think Damien's point is absolutely right. And of course, we also need to look at how do we present to patients about the equipoise and design the right study. Some studies, maybe the crop study was designed in the wrong way. Maybe it should have been head-to-head HIFU to cryo. Or in fact, my initial design was 3 ways: radical prostatectomy, HIFU, and cryo. And my oncology colleagues actually convinced me quite rightly that it was an impossible study to recruit to. So there are studies that will not be able to be recruited to. That is why I propose a cohort study which would take out the equation of randomization in line with clinical practice. You can't just say, well, patient, you cannot have this, while it's actually been shown in multiple cohorts, be it not randomized, to be efficacious.